Welcome, everyone. I want to thank you for taking the time to view my final presentation, and I look forward to discussion and feedback throughout the week. Some background regarding why I chose this. You see the definition of concussion listed there from the 2012 Zurich consensus statement, specific to the biomechanical forces that cause this complex pathophysiological process. Um, I found myself questioning recently if it's only concussion that's occurring following these injuries. Also, I've listed some statistics there for you as far as incidence and prevalence, um, particularly within a high school and collegiate athletic population, suggesting that this is a very common concern and may be on the rise. I had mentioned before this question of whether or not concussion is an isolated injury. With the forces required to cause an injury such as concussion, I often question whether or not there's not a concurrent vestibular dysfunction that's present when trauma occurs to the head or neck or some part of the body that causes these forces to travel to those areas, as well as the common explanation for for how whiplash occurs, which is an acceleration followed by a deceleration, usually found in motor vehicle accidents. I think is very similar to the forces that occur in collision sports. So it really led me to ask this question specific to neck pain for this project as to whether or not these individuals that are suffering head injuries also have some concurrent neck injury due to the crossover of symptoms often used to distinguish subjective reports of head injury, which is the graded symptom checklist within the SCAT-3, and whether or not the neck injury, if it were treated, would improve concussion outcomes. So two different approaches that I will look at for that treatment, one being exercise therapy, as you see the pictures here moving around clockwise, focusing on a cervical neutral position and activation of the deep neck flexor muscles in various postures and with various feedback, progressing to a strength and stability program on the bottom right there with a resistance band, focusing on the cervical retraction motion, and then progressing further to coordinated proprioceptive exercises with eye and head movements as one approach commonly described in the literature to treat whiplash-associated disorders and other various non-specific forms of neck pain. That will be compared to manual therapy and things identified as usually motion restrictions within the facet joints of the cervical spine that are treated with either mobilization or manipulation, and can also be added to various forms of soft tissue release therapy, as you see on the bottom left there of the suboccipital release. So the research question guiding this is exercise therapy more effective at treating cervicogenic symptoms of concussed college students compared to manual therapy? So I mentioned that I work in the collegiate population, specific to the general student population within college health. So the inclusion criteria will be undergraduate and graduate students between 18 to 35 years old that report to a college health center and are diagnosed with a concussion by either an athletic trainer or a physician, and have one or more of the following upon that initial examination: endorsing neck pain within the graded symptom checklist, a range of motion deficit as measured on clinical exam with an inclinometer, positive findings for cervical joint position error and or spasm within their paraspinal or suboccipital musculature. Exclusion criteria will be anything that's contraindicated to either exercise or manual therapy. This could be positive findings specific to the Canadian C-spine rules, one or more of the following suggesting either upper cervical spine instability, such as the Sharp-Purser test or the Ehler ligament test, and or vascular compromise, such as the vertebral-basilar insufficiency screen. Also, exclusion criteria will be comorbid factors that could cloud clinical decision-making regarding symptoms such as mental illness, ADD or ADHD, migraine history, or seizure disorder. The study design will be a point-of-care clinical trial within the Bayesian adaptive design. This will have two arms, either exercise or manual therapy, each having a possibility of improvement or not improvement. So 4 potential outcomes for each patient. No discernible favorite of these approaches was found in the literature. So it will start with an even distribution of 50% of each patient in each group. Every 10 patients that enroll and complete the trial, the data will be looked at and the prior probability will be adjusted based upon those findings. And the trial will be stopped after either 40 patients and no significant difference has been found, or when one of the therapies has been shown to be 80% more effective than the other. The outcome variables that will ultimately judge success, three things will be tracked for clinical correlation. The first being cervical joint range of motion, but that will not play into the reallocation of patients from an adaptive design approach because no baseline data will exist on the individual's cervical joint range of motion. So it will be unable to know for sure if they have returned to their actual baseline. The other measures that will be used for this to judge success or improvement of symptoms will be the numeric pain rating scale that has been shown in this population with individuals with neck pain to have a minimally clinically important difference of 2.5, as well as the Neck Disability Index, which is a patient-rated outcome tool specific and been shown to be valid and reliable for individuals with neck pain. The MCID with that is 3.5. So improvements on both will be utilized to, beyond the MCID, will be utilized to judge a positive outcome for either treatment. The stakeholders involved in this process will start with the patients. The engagement plan there will be through marketing and educational materials sent out either via electronic means such as the website or email, and or meetings with representatives of individual groups such as club sports or student activities organizations. Internally within the campus health, engaging physicians and athletic trainers through educational materials, most likely presentations at meetings for each of these groups to get them on board with the study and make sure they understand their roles and are trained appropriately in the evaluation methods that are needed to collect data and enroll patients. Securing the support of the administration within the health center to make sure that they're on board with the measures being collected and the purpose of the study, and then also the institutional review board will have to be involved through their normal application processes. From a feasibility standpoint, a couple challenges may identify themselves. None do I believe would be a barrier to my current situation, but if were repeated in other environments, the clinic structure or culture in general could be a challenge if either the physicians or the athletic trainers are not on board and enrolling patients, or particularly if the structure is such that athletic trainers are not involved in the campus health community at a particular college or university setting, then the study may not get off the ground if there's no one available in-house to perform the rehab measures to collect the data. Clinicians not comfortable with manual therapy and or state practice acts that do not explicitly allow the practice of manual therapy in individual settings could be a barrier to certain places, but hopefully that would be overcome as studies like this do start to show benefits of particular treatments for patients like this. Also a barrier could be the volume of patients. I can speak from personal experience that that won't be an issue in my current setting, but oftentimes these patients may not report to student health with concerns such as concussion, and that could be a challenge in enrolling patients if this were to be repeated somewhere else. From a significance standpoint, obviously the improvement of outcomes within patients with concussion is a very hot topic right now within sports medicine literature. Could be used to guide future research and help to answer the question as to whether or not concussion is actually an isolated injury or if it often occurs with concurrent other pathologies such as neck pain or neck-related disorders. And really the ultimate thing here could be the saving of both time for the patient as well as healthcare dollars by preventing unnecessary or prolonged symptoms following a condition such as concussion, and really starting to show at the point of care that a more active approach is preferred rather than a wait-and-see approach with symptoms for concussion management. And actually treating things that are found on exam even while a patient is still symptomatic may be the best course of action. So thank you again for your time, and I look forward to your feedback.